Welcome to the final countdown. This is a high-speed review for the final. Let's work.
All right, let's jump right in. We have a ton of high-yield information to get through. This deep dive is all about three critical systems: sensory, elimination, and the acid-base balance that really ties everything together.
We're aiming for maximum factual density here, but with the clinical context, you need to actually remember it on test day.
Exactly. So let's start with sensory.
Okay, sensory deficits. Let's unpack the eye. Visual disorders, I find, are always heavily weighted on safety and that really rigorous post-op teaching. First on the list, cataracts.
Right, so the basic patho is that the lens gets cloudy, opaque, because proteins start clumping together.
Which causes the classic blurriness, but also that light dispersion, right? The glare, the halos around lights at night.
Exactly. And the most important clinical nugget to remember here is that cataracts are, usually age-related. They're progressive, but they are not a medical emergency. The surgery is elective.
And that surgery is a synthetic lens replacement. So let's get into the post-op restrictions, because that's where all the safety questions come from.
It is. You have to have absolute strict adherence to the eye drop schedule. It's usually an antibiotic, a steroid, and a lubricant.
Infection, inflammation, comfort.
Got it.
But the priority teaching is really about preventing mechanical trauma and managing that intraocular pressure, the IOP.
Yes. For trauma, it's pretty straightforward. An eye patch or a shield at night so they don't accidentally rub or hit the eye.
And we tell them to try not to sleep on the surgical side
Right.
to avoid that direct pressure.
Correct. But let's really zoom in on the IOP management. This is the cornerstone. This is what you'll be tested on.
The core rule is simple: no straining at all. So that means no heavy lifting, no bearing down for a bowel movement, and critically, no bending at the waist. Why is that specific movement so important?
You have to explain the why so it sticks. When you bend forward at your waist, you're acutely kinking the venous return from your head. That causes an immediate spike in pressure inside the eye.
And the post-op eye just can't handle that pressure spike.
Not at all. So you have to instruct your patient, you must keep the eye above the level of the heart. Always. If you need to pick something up, you squat. You don't bend.
That distinction is so key. Squat, don't bend. Okay, what about long-term teaching for safety and quality of life?
Once they're recovering, you have to stress UV polarized sunglasses to protect that new lens. We also tell them no driving at night, at least for a while, because of that residual glare sensitivity. And of course, you emphasize eye vitamins and a diet with lots of fruits and vegetables.
Which is a perfect transition to glaucoma, which is a true pressure crisis.
It is. Glaucoma is all about high IOP. And the classic insidious symptom is the loss of peripheral vision. It creates that tunnel vision, which, as you can imagine, dramatically increases the risk for falls and makes driving incredibly dangerous.
And we have to differentiate the two types based on how fast they hit. There's acute glaucoma, or open angle.
That's the one that hits like a ton of bricks. Sudden, rapid onset, it's intensely painful, and it is a medical emergency. You have to get that pressure down immediately to prevent blindness.
Then you have chronic glaucoma, or closed angle. This is the one that sneaks up on you.
It's the silent killer of vision, truly. It's so gradual, the patient might not even notice until, 80% of their peripheral vision is already gone. So it's not an emergency at the moment of diagnosis, but it absolutely requires meticulous, lifelong management.
And the treatment for both is all about relentlessly lowering that IOP. This means eye drops, usually beta blockers and prostaglandin analogs.
Yes, but the procedure for giving those drops is a high-stakes skill. It's not just about getting the drop in the eye.
Okay, let's walk through it. Wash hands, pull the lower lid down, drop into the conjunctival sac. But then comes the critical step.
You have to apply pressure against the lacrimal duct for a full 30 seconds. This is a major test point.
30 seconds. Why? Why can't we just let it absorb?
Because that lacrimal duct is a direct pipeline to systemic circulation, it drains into the nasal cavity where it gets absorbed by the mucous membranes. For a beta blocker, that's dangerous.
So systemic absorption of a beta blocker could tank their heart rate or their blood pressure.
Exactly. Especially in an older adult with existing heart conditions. Those 30 seconds of pressure are non-negotiable. It's protecting the patient's heart.
So safety teaching for glaucoma is all about managing that functional deficit, reducing fall risk, making sure they have good lighting, and teaching them the warning signs of an IOP spike.
Right. Sudden, intense eye pain, a bad headache, maybe nausea and vomiting. That means the pressure is dangerously high and they need to seek care.
All right, let's move deeper into the eye. The retina. A detached retina is a major one.
Hmm.
What are the hallmark symptoms?
It's the new onset of floaters and flashing lights. The classic description is a curtain being drawn across their vision. But what's the key symptom that's missing?
Pain. There is absolutely no pain with the detachment itself, which is tricky because patients might delay seeking help.
Exactly. The causes are usually some kind of mechanical trauma, a car accident, a sports injury, even electrocution. Or it can be spontaneous, especially in people with really high prescriptions because their eyeball is literally stretched.
And the treatment is immediate surgical reattachment to save the vision.
Now, let's contrast that with macular degeneration. This is age-related and it hits the central vision, so it's the opposite of glaucoma.
And it's largely unpreventable, so our focus is on management.
Right. For the wet form, we now have injections that can prevent progression. But from a nursing standpoint, the focus is safety. Their central vision is gone, so they can't drive. You have to make sure they have transportation to their appointments and that their home is set up safely.
Let's touch on hemianopsia really quick. A visual field cut, usually from a stroke.
With this, you can't fix the vision itself. The damage is in the brain. So your focus is 100% on safety and adaptation.
Meaning, you teach the family to approach from the side of their preserved vision. You teach the patient to scan their environment.
And you modify the living space. Moved the dinner plate, the water cup, everything to the side where they can see it. It's all about preventing falls and reducing their anxiety.
Okay, 2 critical emergency eye trauma scenarios. First, a penetrating injury.
Yep.
Something is stuck in the eye. What's the absolute first priority?
Stabilize and cover. You stabilize the object where it is. Do not try to pull it out. Use a paper cup, tape it down, whatever you need to do to keep it from moving.
And then the really critical step, cover both eyes.
Yes. People always question this. Why cover the good eye?
Because of sympathetic movement. If the uninjured eye moves, the injured eye moves with it, and that object is going to tear more tissue. Covering both puts the eyes at rest.
Perfect. Second emergency, chemical exposure.
Time is tissue. The intervention is immediate and non-negotiable.
Flush immediately with copious amounts of water.
Woof.
The rule is 15 to 20 minutes of continuous low-pressure flushing. Get them to an ER, but do not delay the flush. Start it on site.
All right, that's a solid run-through of sensory. Let's pivot now to elimination. The kidney. This is high-density, lab-heavy territory.
It is. Let's start with some key renal terminology that often gets confused. Anuria is easy. No urine output, less than 50 ml in a day.
Then azotemia, that's just elevated toxins in the blood. Your BUN and creatinine are high.
And uremia is when that azotemia becomes symptomatic, when the patient starts showing clinical signs of that toxicity, confusion, itching, pericarditis. That's uremia.
Okay, now we have to address the definition of oliguria from the source material because it's weird.
It is. So clinically, in the hospital, oliguria means low urine output, less than 400 milliliters a day. However, for this specific review, the source defines oliguria as too much urine.
That is incredibly confusing. So we need to flag that for anyone listening. Why would they define it that way?
It's an unusual classification. My best guess is it's linking to the polyuric phase of AKI recovery, where the kidneys suddenly start dumping massive amounts of unconcentrated urine. But for test-taking purposes, you have to know that non-standard definition from the source. It's a know your source situation.
Got it. A necessary, if confusing, caveat. Let's move to the serum labs. These are our anchors. Let's start with creatinine.
Creatinine is the gold standard. It's a waste product from muscle, and it is almost exclusively cleared by the kidneys. So if creatinine is high, it's a very pure indicator of kidney dysfunction.
Compare that to BUN, blood urea nitrogen.
BUN is also indicative, yes, but it can be confounded. If your patient is dehydrated, BUN will go up. If they have liver failure, BUN will go down. It's just not as specific as creatinine.
Third lab, and this is the emergent one, potassium.
Absolutely. The kidneys are the primary excretors of potassium. When they fail, potassium builds up. And because of its effect on the heart's electrical conduction, hyperkalemia is the most immediate life-threatening electrolyte imbalance in renal failure.
And finally, pH. The kidneys manage bicarb, so they play a huge role in the body's acid-base balance.
Exactly. Now let's quickly review the 3 key hormones for blood pressure and fluid balance. ADH from the pituitary,
Retains water.
aldosterone from the adrenals,
Retains sodium, and water follows the sodium.
and renin from the kidneys themselves.
Part of the RAAS system. It causes vasoconstriction, which jacks up the blood pressure. This is why CKD patients have such terrible hypertension. Their damaged kidneys are still screaming, produce renin.
Perfect. Now let's differentiate the major kidney syndromes. We can use the mnemonic Itis keeps things in, and atyl lets things out ear.
Okay, so glomerulonephritis, that's our itis syndrome.
Right.
What's the cause?
It's inflammation, usually caused by these big, sticky antigen antibody complexes that get stuck in the glomeruli. The classic trigger, especially in kids, is a recent strep throat infection.
So those complexes clog up the filter, they block it.
Right. And that blockage severely drops the GFR. So the primary complication is everything gets kept in, specifically fluid. So you see massive fluid volume overload, hypertension, and edema.
Which means the treatment is aimed at the inflammation and the overload, steroids for the inflammation, antibiotics for the strep, and a strict sodium limit.
Exactly. Now let's contrast that with nephrotic syndrome, the aortic syndrome where everything leaks OUT.
The cause here is increased capillary permeability. The source material says 9 out of 10 cases are caused by sepsis.
Right, so it's usually a secondary result of a massive systemic insult. The capillaries become incredibly porous, and the result is massive proteinuria.
Meaning tons of protein, specifically albumin, is just dumped into the urine.
Yes, and when you lose that albumin from the blood, you lose your oncotic pressure. You can't hold fluid inside the blood vessels anymore.
Which leads to profound third spacing. The patient is edematous everywhere, but intravascularly, they're dry.
Exactly. They look like the Michelin Man, but their blood pressure is in the toilet. And you'll see that classic foamy urine because of all the protein.
So the treatment priority is to find and treat the cause, which is usually sepsis. But we're also giving IV fluids and albumin replacement.
And that seems paradoxical, right? Giving fluid to a patient who's drowning in it. But you have to remember, their vessels are dry. You have to restore that intravascular volume and oncotic pressure to pull the fluid back out of the tissues.
Okay, next up, pyelonephritis. This is just a straight-up kidney infection.
Yep, a bacterial infection that has ascended into the kidney tissue. The key teaching point here is how it presents in older adults.
Right. It might not be the classic flank pain and fever. An older adult's first sign might just be confusion or delirium.
Absolutely. And you have to know the long-term risk. Chronic recurrent pyelonephritis leads to scarring, and that scarring can destroy enough kidney tissue to cause end-stage renal disease.
So prevention is key. Proper hygiene to prevent UTIs in the first place.
And lastly, nephrosclerosis. This is a vascular problem. It's hardening of those tiny afferent arterioles leading into the kidneys.
Usually caused by long-term uncontrolled hypertension or diabetes.
Right. And it creates this vicious cycle. The narrowing causes more hypertension, which causes more damage. The teaching here is a massive lifestyle change. Low cholesterol, low sodium diet, smoking cessation, and tight blood glucose control.
Okay, let's drill down now into acute kidney injury, or AKI. We have to know the 3 categories: pre, intra, and post-renal.
The easiest way to think about it is location. Is the problem with the plumbing to the kidney, that's pre-renal, is the problem within the kidney itself, intrarenal, or is the plumbing away from the kidney blocked, post-renal?
Let's start with PRE renal, blood flow issues. So things like low cardiac output, sepsis, a major hemorrhage, or just severe dehydration.
Anything that starves the kidney of blood. So prevention is all about perfusion. You maintain fluid volume, you stop bleeds, you treat the underlying infection, you get blood to the kidney.
Next, intrarenal. This is direct damage to the kidney tissue. We've talked about the apoditis conditions.
Right, but the big focus here is nephrotoxicity, specifically nephrotoxic medications, the aminoglycosides, the mycins, and IV contrast dye.
Prevention here is specialized. If you have to give a mymicin, you monitor peak and trough levels. Let's review that timing.
Peak is drawn 30 to 60 minutes after the dose to make sure you have enough drug to be effective. Trough is drawn 30 minutes before the next dose to make sure the level has dropped enough to not be toxic.
And for contrast dye, we use nephroprotective drugs. The big one is N-acetylcysteine.
Right, which has that lovely rotten egg, sulfurous smell. It's a free radical scavenger. It protects the kidney and the liver. We also give IV bicarb to reduce the acid load on the kidneys from the dye.
And finally, post-renal. This is an obstruction after the kidney. So a UTI, a kidney stone, BPH in men, or even just a kinked Foley.
Prevention here is just about keeping the pipes clear. Treat UTIs, push fluids for stones, manage BPH with meds or surgery.
And a huge part of that is CAUTI prevention, catheter-associated UTIs.
Yes. We use a stat lock to prevent friction. The goal is to get the catheter out as soon as humanly possible. If you can, transition to an external device like a PureWick for female patients.
And let's be clear on the only reasons for a catheter: refractory urinary retention, strict IOs in a critically ill patient, large genital wounds, or certain bladder surgeries. That's it.
Exactly. Okay, so that's AKI. But AKI can progress to chronic kidney disease or CKD. Let's talk about the systemic consequences.
Do it system by system. Cardiovascular.
This is the #1 cause of death in CKD patients. They're dealing with constant fluid volume overload and that severe renin-driven hypertension.
So treatment is aggressive antihypertensives and statins, because CKD also causes hyperlipidemia, which accelerates atherosclerosis.
Right. Next, hematological. CKD patients are always anemic.
Because the kidneys make erythropoietin, or EPO, which tells the bone marrow to make red blood cells. No kidney function, no EPO.
So we give them replacement therapy. EPO alpha. It's a sub-Q injection, usually 3 times a week, often given right at their dialysis appointment.
Neurological.
The toxin buildup, uremia, is incredibly neurotoxic. It causes altered mental status, confusion, and can even lead to seizures.
So the primary intervention is dialysis to clear the toxins. And for seizure prophylaxis, a low-sodium diet is important.
Integumentary. They have chronic edema, but also this intense itching, this pruritus.
From the unfiltered salts and waste being deposited under the skin.
Exactly. It makes them prone to skin breakdown. So you need meticulous, fragrance-free hygiene.
And finally, metabolic acid base.
They're in a constant state of compensated metabolic acidosis because they can't excrete acid.
Which is why you see them with that rapid, deep, cuspmal breathing. Their lungs are trying to blow off CO2 to compensate. We often have to give them bicarb supplements.
All right, let's hammer the CKD electrolyte imbalances. This is high priority life or death stuff. What's the pattern?
Everything is high except for calcium. So always sodium or potassium, or phosphorus, but all calcium.
Which means the diet is a nightmare for patients. Low sodium, low potassium, low phosphorus, but high calcium and high iron.
Let's focus on hyperkalemia. This is the big emergency. How do we manage it?
Okay, non-emergently, you can use oral meds like polystyrene sulfonate or Patarimer to bind potassium in the gut, and Lasix if they still make urine.
But in a true emergency, when that potassium is over 6, what is step 1?
Step 1 always is IV calcium gluconate, and this is critical. It does not lower the potassium. It stabilizes the cardiac membrane. It protects the heart from the high potassium, buying you time.
So you protect the heart first. Then what's step 2?
Then you shift the potassium. The fastest way is insulin plus dextrose. The insulin drives potassium from the blood back into the cells, and you give the D50 to prevent hypoglycemia from the insulin dose.
And while you're doing all this, you're watching the ECG for those classic signs.
Peaked T waves first, then a widened QRS, and a prolonged PR interval. The heart gets irritable, then it gets tired and slows down.
Okay, now the other side of the coin, the hypocalcemia and hyperphosphatemia. Let's talk tetany.
It's a progression. Early on, it's peripheral tingling and numbness, especially around the mouth and fingertips.
Then it moves to muscle cramps and spasms. And then the late classic signs.
Schwastek sign, where you tap the cheek and the face twitches. And Trousseau's sign, where you pump up a blood pressure cuff and their arm curls into a spasm.
And the ultimate risks are laryngospasm, which can close their airway, and cardiac dysrhythmias.
And don't forget the bones. The low calcium makes the parathyroid gland go into overdrive, pulling calcium from the bones. This leads to bone pain, osteoporosis, and a huge fracture risk.
So, interventions. How do we fix the calcium-phosphorus problem?
You give phosphate binders, like sevelamer, but they only work if you give them with food. They have to bind the phosphate from the meal in the gut.
And then you give calcium and vitamin D supplements, and in a severe case.
IV calcium gluconate again, but remember, it's a vesicant. It needs a big vein or a central line and a slow push.
Okay, let's talk fluid volume overload, or FVO. How does it present?
Pulmonarily, it's the most dangerous. Increased respiratory rate, low O2 sats, crackles in the lungs, and in the worst case, that pink frothy sputum of acute pulmonary edema.
And externally, you see the pitting edema, JDD, high blood pressure, and bounding pulse.
Labs will look dilute. So low sodium, low BUN because there's so much extra water.
Interventions start with restrictions. Sodium and fluid restriction. Loop diuretics like furosemide.
Right, and you elevate the legs, do strict IOs, daily weights. If it's severe, you might need seizure precautions because of the hyponatremia.
And for serious FVO, you're looking at dialysis or maybe mannitol.
Mannitol is our osmotic diuretic. It's great for pulling fluid from tissues, which is why it's also our go-to for increased intracranial pressure, ICP.
But it has that special administration rule. You have to use a filter.
Yes, because it can crystallize at room temperature. The filter catches those crystals so you don't infuse them into your patient.
Okay, rapid fire on the key renal meds. Furosemide.
Loop diuretic, potassium wasting.
Spironolactone.
Potassium sparing.
Mannitol.
Osmotic diuretic for FVO and ICP.
Acetylcysteine.
Protects kidneys from contrast. Tylenol antidote.
Bicarb.
Fixes acidosis. Protects from contrast.
Phosphorus binder.
Gives with food.
Epoetin alpha.
For anemia, increases red blood cells.
Perfect. Let's move to dialysis access. This is all about nursing assessment and safety.
Starting with central lines. The VASCAF is temporary. It's a big catheter in a major vein.
Highest infection risk. Only stays in for 2 or 3 weeks. Needs an X-ray to confirm placement. And there's a risk of pneumothorax on insertion.
And the absolute rule. Never used by floor nurses. It's for dialysis only.
The permacath is the semi-permanent option. It's tunneled under the skin.
Right, which lowers the infection risk. It can stay in for up to a year. Same rules apply, though. Same risks on insertion.
Now for the long-term options. The AV fistula. This is the gold standard.
It is. They surgically join an artery and a vein. It's the patient's own tissue, so it has the least complications and lowest infection risk. It can last a lifetime.
The other option is an AV graft, which uses synthetic tubing to connect the artery and vein.
Fails more often than a fistula, has a higher infection risk, but it's an option if the patient's muscles aren't suitable for a fistula.
But the critical nursing care is the same for both. This is what you must do every single shift.
You palpate for the thrill, that buzzing, purring vibration that tells you there's good flow.
And you auscultate for the brute, that whooshing sound.
If the thrill or brute disappears or changes, that's an emergency. It could be clotting off. You have to notify the provider immediately. It's their lifeline.
And the protection rules are absolute. No BPs, no sticks, no tight clothing on that arm, ever.
Exactly. Okay, lastly, peritoneal dialysis, or PD.
This uses a tank-off catheter into the peritoneal cavity. You pump in dialysate.
The peritoneum acts as the filter, toxins diffuse across, and then you drain it out.
The big pro is they could do it at home. It's much more independent.
The big life-threatening con is the risk of infection, peritonitis.
How does that manifest?
A rigid, painful abdomen, and the key sign is the effluent. The drained fluid will be cloudy instead of clear. That's a medical emergency.
All right, one last quick hit section for this deep dive, a review of acid-base balance and ABGs.
Okay, you have to have the normals memorized. pH, 7.35 to 7.45, CO2, respiratory, 35 to 45, and HCO3, bicarb, metabolic, 22 to 26.
We use the Rome mnemonic, respiratory opposite, metabolic equal, and we need to remember the speed of compensation.
The lungs are fast. They can change your CO2 level in minutes by changing how you breathe.
And kidneys are slow. They take hours or days to change your bicarb level.
So an acute problem will be uncompensated. The opposing system's value will still be normal. A chronic problem will be compensated. The opposing system will have changed to try and fix the pH.
So let's run a quick scenario. A CKD patient in metabolic acidosis, their pH is, say, 7.36, their bicarb is 20, and their CO2 is 33.
Okay. The pH is low on the acid side. The bicarb is low, also on the acid side, so it's metabolic acidosis.
But the CO2 is 33. Normal is 35, 45, so it's on the low side, the alkalotic side.
Right. So the lungs are compensating. They're blowing off CO2 to try and raise the pH. Because the pH is still not quite back to normal, we'd call this partially compensated metabolic acidosis. That's the level of interpretation you need.
That covers the sensory and elimination systems. Now let's switch gears immediately to growth, development, and mental health.
All right, picking up right where we left off, let's look at growth and development, starting with pregnancy and delivery.
Yes. We have a huge amount to get through here. And really, for maternity care, the absolute first step is just confirming the pregnancy.
Right. You can't manage what you haven't diagnosed. And the signs are broken down into 3 categories, which is a really common test question.
It is. The categories basically tell you how certain you can be. We start with presumptive signs.
Presumptive. So this is like circumstantial evidence. It's all subjective, stuff the patient reports.
Exactly. Things like nausea, vomiting, feeling exhausted, or the classic one a missed period, amenorrhea.
It makes you suspicious, but it's definitely not proof.
Not at all. So then you step up to the probable signs. Now, these are objective. An examiner can actually see or measure them.
Okay, so this is stronger evidence, but still not 100% definitive.
Right, because other things can cause them, like certain hormonal issues or even a molar pregnancy, which can produce a lot of HCG.
And these are the big ones to know. A positive HCG test, which, is surprisingly only probable.
Yep. Then you have the physical signs, Goodell sign, which is the softening of the cervix.
And Chadwick's sign. That's that bluish-purple color of the cervix and vagina from all the increased blood flow.
And Hagar's sign, the softening of that lower part of the uterus, you can feel it. It's objective, but it's still not the final word.
So that brings us to the positive signs. This is the slam dunk, the DNA evidence.
Exactly. There are only 3, and they are foolproof. They confirm, without a doubt, that there is a living fetus in the uterus.
Okay, so number 1 is seeing the fetus on an ultrasound.
Can't argue with that.
Yeah.
Number 2 is hearing the fetal heart tones, usually with a Doppler around 10 to 12 weeks.
And number 3, which is maybe the oldest method, is when an experienced provider actually palpates or feels the fetal movement.
If you can see it, hear it, or feel it move yourself, it's positive.
Perfect. So moving on to the timeline. We divide pregnancy into 3 trimesters, and each one has a completely different focus.
Totally different. The first trimester, so it's weeks 1 through 12, it's the most critical and vulnerable time.
This is organogenesis, right? When everything is being built.
Everything, the organs, the structures, it's all forming. This is when the fetus is most susceptible to teratogens, those agents that cause malformations.
A problem here can affect the whole blueprint of the baby.
For sure. Then in the second trimester, weeks 13 to 27, the focus shifts. It's less about formation and more about growth and maturation.
And this is when mom starts to feel the baby move. That's called quickening, right?
Yep, usually between 16 and 20 weeks. It's a huge milestone.
And this is also when we start doing fundal height checks.
Critical check. After 20 weeks, the measurement in centimeters from the pubic bone to the top of the uterus should roughly match the gestational age in weeks.
Plus or minus 2 centimeters. If it's way off, that could signal a problem like too much amniotic fluid or intrauterine growth restriction.
Exactly. Then the third trimester, weeks 28 to 40. This is all about rapid weight gain and final lung maturity.
And the visits become much more frequent from every 4 weeks to every 2 weeks because we're getting close.
Right. Monitoring ramps up.
Okay, let's talk labs. The initial safety screen. We're looking at a baseline CBC, STI screenings, and a really important one, the rubella titer.
The rubella titer is a huge safety point. If the mother's not immune, you absolutely cannot give her the live rubella vaccine while she's pregnant.
Because it's a live virus, it could cross the placenta and cause defects.
Precisely. She has to wait until after she delivers.
And we have to talk about Rh factor and RhoGAM. This is all about prevention.
It is. If you have an Rh negative mom and an Rh positive fetus, their blood is incompatible. If their blood mixes, say during delivery, the mother's body can develop antibodies.
And those antibodies won't hurt the current baby.
Right. But they'll be waiting in her system, ready to attack the red blood cells of the next Rh-positive baby she carries.
Right.
It can cause severe hemolytic disease.
So timing is everything. We give RhoGAM to prevent her body from making those antibodies in the first place.
We give it prophylactically around 28 weeks. And then if the baby is born Rh positive, she gets a second dose within 72 hours postpartum.
It's like an immunological decoy.
That's a great way to put it. We also screen for Group B strep, or GBS, but that's much later, around 35 to 36 weeks.
And GBS is usually harmless to the mom.
Totally harmless to her.
Right.
But if she's positive, the baby can pick it up during delivery and get very sick with sepsis or pneumonia.
So the intervention is simple. IV antibiotics for mom during labor.
That's it. It protects the baby on its way out.
Beyond labs, patient teaching is huge. Let's hit the high-yield restrictions. First, no alcohol. 0.
0 is the only safe amount. The risk of fetal alcohol spectrum disorders is too high. And no smoking.
Smoking constricts those placenta vessels, which means less oxygen and nutrients. It's a huge risk for growth restriction and asides.
And we need to be really clear on medications. It's Tylenol only for pain. Absolute no NSAIDs like ibuprofen.
Especially late in the 3rd trimester. Why is that?
Because NSAIDs can cause the ductus arteriosus in the fetus's heart to close prematurely. That leads to severe pulmonary hypertension at birth. It's a disaster.
Wow, okay. That's a critical connection to make. What about things like hot tubs or saunas?
Also a no-go. Maternal hyperthermia, getting too hot, especially early in pregnancy, is a major risk factor for neural tube defects.
It interferes with cell division. And one more, a subtle seatbelt safety.
Yes, the lap belt goes low, under the abdomen, across the hips, not across the belly. The shoulder strap goes right between the breasts.
That way, the force of a crash is distributed away from the uterus.
Exactly.
Okay, let's transition into actual delivery. We need to master the 3 Ps of cervical progress. dilation, effacement, and station.
The absolute backbone of labor monitoring. Dilation is the opening, from 0 to 10 centimeters. 10 is complete.
Effacement is the thinning of the cervix. It goes from 0 to 100% where it's paper thin. You need both to happen.
You do. And station tells us how far down the baby is. We use the ischial spines in the pelvis as the 0 mark.
So 0 station means the baby is engaged.
Engaged. Negative numbers like -3 mean the baby is still high up or floating. Positive numbers mean the baby is descending on the way out.
+5 is on the floor.
Pretty much. And fetal presentation is just as important. The best case scenario is cephalic, head down, specifically occiput anterior.
Back of the baby's head toward the front of mom's pelvis. It's the best fit.
It is. Breech, which is feet or butt first, or transverse, where the baby is sideways, those almost always mean a C-section.
Okay, stages of labor. Stage 1 is the longest. It goes from the start of contractions all the way to 10 centimeters.
And we break stage 1 into 3 phases. Latent, from 0 to 3 centimeters. Mom is usually talkative, excited.
Then active, 4 to 7 centimeters. Contractions are stronger, more frequent. She's getting more focused.
And then comes transition, 8 to 10 centimeters.
This is the real deal. Shortest but most intense phase.
Oh yeah. Contractions are almost on top of each other. Patients often get nauseous, vomit, hyperventilate. They can feel panicked. It's our job to be that calm anchor.
Then stage 2 is the push-in stage, from 10 centimeters until the baby is born.
Stage 3 is the delivery of the placenta. And the key nursing action here is to check and make sure that placenta is completely intact.
Because if any pieces are left behind...
Massive risk for postpartum hemorrhage and infection.
Okay, let's get into some of the scarier stuff. Complications and emergencies. What if the membranes rupture and the fluid isn't clear?
Right. If you see meconium-stained fluid, that greenish-brown color, that's a warning sign.
Meconium is the baby's first stool. So if it's in the fluid, it means the baby was under stress in utero.
Fetal distress, hypoxia. The big danger is meconium aspiration syndrome. If the baby breathes that thick fluid in with its first breath, it can cause a severe respiratory blockage.
That requires a specialized resuscitation team at delivery.
Immediately. But the ultimate OB emergency has to be a prolapsed umbilical cord.
This is when the cord slips down ahead of the baby after the water breaks.
And the baby's head or shoulder then acts like a vice, compressing the cord and cutting off all oxygen. You have minutes, not hours, minutes.
So the actions have to be instant. What do you do?
First, call for help and prep for an emergency C-section. Second, you have to reposition the mom to get gravity on your side, Trendelenburg, or a knee-chest position.
And third, the most critical step.
You insert a sterile gloved hand into the vagina, and you physically lift the baby's presenting part off of the cord. You hold it there.
You literally hold the baby up off the cord until the surgeon can get the baby out.
You do not move your hand.
Wow. Okay, medications in labor. Oxytocin or pitocin. We use it to start or strengthen labor.
And just as importantly, we use it after delivery to control postpartum hemorrhage by making the uterus clamp down.
But you have to know when to stop it. What's the rule?
If contractions are lasting longer than 90 seconds, or they're happening too frequently without a break, you stop the infusion. You risk uterine rupture or fetal distress.
Okay. And then we have magnesium sulfate. This drug is fascinating because it has two major distinct uses.
It does, and it all comes back to its main job. It's a smooth muscle relaxant.
So use number 1, it can stop preterm labor. That's called tocolysis. It relaxes the uterine muscle.
Exactly. But use number 2, and maybe the more tested one, is to prevent seizures in patients with severe preeclampsia or eclampsia.
It calms down the central nervous system.
It does. So it's the same drug, but one use is relaxing the uterus, the other is relaxing the brain.
And because it's a CNS depressant, you have to watch for toxicity, decreased reflexes, respiratory depression.
And you have to have the antidote at the bedside, calcium gluconate.
Always. Okay, epidurals. The primary risk is what?
Maternal hypotension. That sudden vasodilation can shunt blood away from the placenta, and that can cause the fetal heart rate to drop.
So to prevent that, we preload them with IV fluids.
A fluid bolus, yes. Usually about a liter to a liter and a half of lactated ringers before the anesthesia's even started. It acts as a buffer.
And then you're just watching that blood pressure and the fetal heart rate like a hawk?
Relentlessly.
All right, baby's out. We're in the postpartum period. The assessment acronym is BBBLES. Let's focus on uterus, bladder, and lochia.
The big 3 for hemorrhage risk. U is for uterus, or the fundus. Normal descent is about 1 centimeter per day.
Right after birth, it should be firm and right at the level of the umbilicus.
Firm is the key word. If you feel a boggy uterus, soft, mushy, that's a red flag. The muscles aren't clamping down.
And the immediate intervention for a boggy uterus is fundal massage.
You get in there and you massage it aggressively to stimulate that contraction. But there's a catch.
The bladder, the B in Bobie Ellis.
Exactly. A full bladder will push the uterus up and to the side, and it prevents it from contracting properly. It makes the bleeding way worse.
So this is a classic what do you do first question. If the fundus is boggy A and D displaced, your first step is?
Get the patient to pee. Empty the bladder. You assist them to the bathroom or use a catheter. Then you recheck the fundus and massage if needed.
You can't fix the uterus until you fix the bladder.
You got it. L is for lochia, the postpartum discharge. It changes over time.
Rubra is the first few days, bright red. Then serosa, which is pinkish brown. Then alba, which is creamy white.
The danger sign is soaking more than one pad in an hour. Or, if the bleeding goes backwards, say, from serosa back to bright red rubra, that's a concern for late hemorrhage.
And we also have to touch on postpartum mental health, differentiating the blues from depression.
Postpartum blues are super common, last less than 2 weeks. It's related to hormones and sleep deprivation, but it does not interfere with her ability to care for herself or the baby.
Postpartum depression is when those symptoms last longer than 2 weeks, and they do start to interfere with daily life and bonding. That needs intervention.
And then there's postpartum psychosis. Rare, but a true medical emergency. We're talking delusions, hallucinations, and a serious risk of harm to self or the infant.
That requires immediate inpatient treatment.
No question.
Okay, shifting gears to the newborn. The very first assessment is the APGAR score.
Done at 1 minute and 5 minutes of life. A healthy normal score is between 8 and 10.
And if it's low at 5 minutes, you keep assessing. It tells you if the baby needs resuscitation.
The immediate priorities after that are the ABCs and, critically, thermoregulation. You have to keep that baby warm.
And if a baby's temperature drops, you have to do a glucose check. Why?
Because babies create heat by burning through their energy stores, and that can rapidly cause hypoglycemia. It's a vital connection to make.
Okay, prophylactic meds. All newborns get vitamin K.
Intramuscularly, yep. Because their gut is sterile at birth, so they can't make their own clotting factors yet.
They also get erythromycin eye ointment to prevent blindness from STIs and the Hep B vaccine.
That's the standard bundle. And for screening, the PKU blood test is essential, but there's a key timing element.
It has to be done after the baby's first feeding.
Yes, because it's testing for the ability to metabolize proteins. If the baby hasn't eaten any protein, the test is useless.
And for safety teaching before they go home, SIDs prevention is number 1.
Back to sleep. The baby sleeps alone, on its back, in a crib. Firm surface, no loose bedding, no co-sleeping.
We have to recognize abnormal findings, too. Jaundice is a big one.
That yellowing of the skin from bilirubin buildup. If it gets too high and goes untreated, the risk is kernicterus,
which is permanent neurological damage from bilirubin crossing the blood-brain barrier.
a devastating but preventable outcome. You also might see a cephalohematoma,
A collection of blood under the scalp.
and you have to watch that closely because as that trapped blood breaks down, it releases a ton of bilirubin, which really increases the jaundice risk.
And one last finding. A simian crease. A single straight crease across the palm.
Strongly associated with Down syndrome.
Okay. That's a whirlwind tour of getting a baby into the world safely. But now we have to talk about how the body defends itself. Let's move to immunity and cellular regulation.
Great transition. Let's start with HIV and AIDS. The fundamental mechanism here is a precision attack.
It specifically targets the CD4 helper T cells.
The generals of the immune system.
Yeah.
They're the ones who activate all the other defenses. When your CD4 count drops, the whole system just collapses.
The infection progresses in stages. There's the acute phase, a couple weeks after exposure, with really bad flu-like symptoms.
Then a long chronic latency phase. The person can feel fine for up to 10 years while the virus is just quietly destroying those CD4 cells.
And the final stage is full-blown AIDS, which is defined by one of two things.
Either the CD4 count drops below 200 cells.
Normal is around 1,000, for reference.
Right, so below 200, or the patient develops an AIDS-defining condition.
And there are two big ones to know for exams. The first is pneumocystis jirovecii pneumonia, or PCP.
A fungal pneumonia that a healthy immune system would just laugh at.
And the second is Kaposi sarcoma.
A type of cancer that causes these dark, bruise-like lesions on the skin or in the mouth. Seeing that as a sign of profound immunosuppression.
So the goal of treatment antiretroviral therapy, or ART, is to get the viral load to be undetectable.
And this is a game changer. Undetectable equals untransmittable. If the virus can't be detected in the blood, it can't be passed to another person.
But that requires incredible compliance with the medication.
Absolutely.
Yeah.
The regimens use 2 to 4 different drugs. If you miss doses, the virus replicates, mutates, and becomes resistant to the drugs.
The therapy stops working.
Exactly. We also have prophylactic options. Pre-EP is pre-exposure prophylaxis,
That's an ongoing daily pill for people at high risk to prevent infection.
and PEP is post-exposure prophylaxis. That's for an emergency, like a needle stick. You have to start it within 72 hours and take it for 28 days.
Okay, let's shift to sickle cell anemia. The medication we really need to focus on here is hydroxyurea.
Right. Hydroxyurea is used to reduce the frequency of painful sickling crises. It works by suppressing bone marrow production.
But that mechanism, bone marrow suppression, creates its own huge set of risks.
A huge risk for infection. Low white blood cell counts mean the patient is neutropenic and needs strict precautions.
And for the nurse, hydroxyurea is a hazardous drug. It's an exposure toxin.
You have to wear gloves, proper PPE. It's handled like a chemotherapy agent.
And the patient teaching is critical. It has a black box warning for immune suppression and a risk of skin cancer.
So they absolutely must be taught to use sunscreen, wear hats, and protect their skin from the sun every single day.
Okay, let's talk about autoimmune disorders, starting with lupus. Systemic lupus erythematosus.
Lupus is where the immune system attacks the body's own connective tissues. And since connective tissue is everywhere, the damage is widespread: heart, kidneys, joints.
And the classic sign we have to recognize is that butterfly rash across the nose and cheeks.
The defining symptom, it primarily affects young women, and there's no single test to diagnose it.
What triggers the flare-ups?
The two big triggers are UV light exposure and getting sick. So the most important piece of patient teaching is aggressive sun protection.
Avoid the sun to avoid the flares. Got it. Now, rheumatoid arthritis, or RA.
With RA, the immune system attacks the synovial joints, hands, knees. The chronic inflammation destroys the joint over time.
And the hallmark symptom that separates it from, say, osteoarthritis is morning stiffness.
Exactly. They wake up with stiff, painful, swollen joints that actually get better as they start moving around during the day.
So patient teaching would focus on doing gentle stretches and exercises in the morning to get moving.
That's a huge part of maintaining their quality of life. For treatment, we often use what's called bridge therapy.
Okay, what's that?
The main drugs, DMARDs, take about 4 weeks to start working. So to get symptoms under control quickly, we use corticosteroids like prednisone to bridge that gap.
They provide fast relief while waiting for the long-term drug to kick in.
Yes. And here is the massive safety point with steroids.
Yeah.
You can never, ever stop them suddenly.
You have to wean off them slowly.
You have to. If you stop abruptly, the body can go into an adrenal crisis, which causes circulatory shock and life-threatening hypotension.
A critical safety warning. Okay, let's wrap up immunity with anaphylaxis.
A type 1 hypersensitivity reaction. The most immediate life-threatening danger is angioedema.
Massive swelling of the face, lips, tongue, and throat that completely obstructs the airway.
The whole pathophysiology is a catastrophe. Massive vasodilation causes blood pressure to plummet, the heart rate skyrockets, and the larynx spasms shut.
So the treatment sequence has to be perfect. Step 1, stop the exposure.
Step 2, use the EpiPen. Immediately. Epinephrine is the antidote. It vasoconstricts to bring the BP up and bronchodilates to open the airway.
Step 3, sit the patient up. Step 4, high flow oxygen.
100% non-rebreather mask. Then you can follow up with antihistamines and steroids.
And you have to know how to use the EpiPen. Orange to the thigh, blue to the sky.
Hold it in the outer thigh for a few seconds, then massage the site. But there's a crucial follow-up point.
Epinephrine has a short half-life. It wears off.
It wears off quickly, but the allergen is still in their system, so they have to go to the hospital every single time. Rebound anaphylaxis is a real danger.
You can give a second dose if needed after 5 minutes, but they are still going to the emergency department.
Non-negotiable.
Okay, moving into our final major section, mental health, defense mechanisms, and psych medications. Let's start with just core concepts for psych care.
When you're dealing with a patient in psychosis, with delusions or hallucinations, the main goal is safety and reality grounding.
And the rule is you validate the feeling, but you do not validate the psychosis.
Perfectly said. You can say, I understand that you feel scared, but you never say, yes, I see the skies in the corner too. You always gently reorient to reality.
And if it's command psychosis, where a voice is telling them to do something?
You have to ask directly, what is the voice telling you to do? You have to assess the immediate risk of harm.
Safety is always first, least restrictive restraints first, and always be aware of your own position in the room stay between the client and the door.
Always have an exit. And we need to be clear on empathy versus empathy.
Empathy is feeling with someone. Think E for experience. You can understand their feeling.
Sympathy is feeling for someone. It's pity. We aim for empathy.
We also have transference, where the patient projects feelings from their past onto the nurse.
And countertransference is when the nurse does the same thing back to the patient. Both can damage the therapeutic relationship.
Okay. Now for a mandatory comprehensive review, we have to go through all 11 core defense mechanisms.
Let's do it. We'll go one by one. First up is repression. This is the unconscious, involuntary burying of a painful memory or thought.
So you genuinely cannot remember it, like a person who was abused as a child and has absolutely no memory of the event.
Exactly. It's completely inaccessible, which is different from our next one, denial.
Denial is refusing to accept reality because it's too painful.
Right. The person diagnosed with a terminal illness who insists the doctors made a mistake and they're perfectly healthy. They're denying the reality in front of them.
Okay, next is regression.
This is reverting to an earlier, more immature behavior when you're stressed.
Like a toilet-trained child who starts wetting the bed again when a new sibling is born, or an adult who throws a full-on tantrum.
Exactly. Then we have projection. This is taking your own unacceptable thoughts or feelings and attributing them to someone else.
So if I'm angry at my friend but I can't admit it, I might say, wow, my friend is really angry with me.
You've projected your anger onto them. Next is splitting.
This is seeing everything in black and white, all good or all bad. No gray area.
Very common in some personality disorders. The nurse is either the best nurse ever or the most evil person in the world with no in-between.
Okay, displacement.
This is taking an emotion you feel toward one source and directing it at a safer, less threatening target.
You get yelled at by your boss, you can't yell back, so you go home and you kick the dog or yell at your spouse.
You displace the anger. Next, reaction formation.
This is behaving in a way that's the exact opposite of how you truly feel.
The classic example is someone who has unconscious homosexual feelings but becomes an outspoken, aggressive homophobe. They're acting out the opposite to hide the truth from themselves.
Then we have rationalization.
Making excuses.
Yeah.
Justifying your behavior with a plausible but false reason.
I had to cheat on the exam because the professor is a terrible teacher and everyone else was doing it.
You're rationalizing the cheating? How about humor?
Focusing on the funny aspects of a painful situation to reduce the anxiety.
A patient going through chemo who makes jokes about losing their hair. It's a way to cope.
One of the healthiest ones is sublimation.
Definitely the most mature. This is redirecting a powerful, unacceptable impulse into a socially acceptable and productive activity.
Someone with intense aggressive urges becomes a surgeon or a professional athlete.
Or channeling that energy into something constructive. And finally, suppression.
Unlike repression, this is a conscious effort to push away an unwanted thought.
You're aware of the thought or feeling, but you deliberately decide, I'm not going to think about that right now. You're putting it on a shelf for later.
Okay, that's the full list. Now let's hit critical psychopharmacology, starting with antidepressants like SSRIs.
SSRIs like sertraline, fluoxetine, they increase the amount of available serotonin, but they come with some major risks.
First, an increased risk of suicidal ideation, especially at the beginning of treatment in younger people.
Second, sexual dysfunction is a very common side effect. And third, they have a slow onset. It takes weeks to feel the effect.
And the life-threatening risk is serotonin syndrome.
Serotonin toxicity. You look for a triad. Mental status changes like confusion, autonomic hyperactivity, so they're sweaty, feverish, tachycardic, and neuromuscular problems like muscle rigidity and tremors.
We also have the older MAOIs, not used as much because of interactions.
The mandatory teaching here is they must avoid foods high in tyramine.
Aged cheeses, cured meats, red wine, chocolate.
Because that combination can cause a life-threatening hypertensive crisis.
Okay, mood stabilizers. The gold standard is lithium.
And it's so tricky because of its incredibly narrow therapeutic range. Anything above 1.5 is toxic.
And the key concept here is the link between lithium and sodium. The kidneys treat them almost the same.
So you can never give lithium to a patient who is dehydrated or has low sodium. The body will hold on to lithium to compensate, and the levels will become toxic very quickly.
Which means they have to avoid things that deplete sodium in fluid, like diuretics, a lot of caffeine, and also NSAIDs.
And the signs of toxicity are things like excessive thirst and urination, vomiting, diarrhea, and coarse tremors.
Now, for antipsychotics, the atypical one, clozapine, has a very unique serious side effect.
It can cause a granulocytosis, a catastrophic drop in white blood cell counts. It requires constant blood monitoring.
And all antipsychotics carry the risk of neuroleptic malignant syndrome, or NMS.
NMS is a medical emergency. You see a super high fever, lead pipe, muscle rigidity, confusion, and seizures.
The first action is to stop the med immediately and start aggressive cooling measures.
Cooling blankets, ice packs. You have to get that temperature down before it causes brain damage.
Finally, a quick review of eating disorders. What's the key difference between anorexia and bulimia?
Body weight. Anorexia is defined by having a significantly low body weight for their age and height. Patients with bulimia can be normal weight or even overweight.
But the health risks are severe for both, especially cardiac risks.
Absolutely. The electrolyte imbalances, especially hypokalemia from purging, can cause deadly arrhythmias. You'll see prolonged PR and QT intervals on the EKG.
And we also see metabolic shifts. Vomiting leads to metabolic alkalosis from losing stomach acid.
And chronic laxative abuse leads to metabolic acidosis from losing bicarbonate in the stool.
Last concept here, refeeding syndrome.
When you reintroduce nutrition to a severely malnourished patient, you have to do it very slowly.
A sudden flood of calories can cause massive fluid and electrolyte shifts, especially with phosphorus, that can overwhelm the heart and lead to respiratory failure.
Slow and steady is the only safe way.
That wraps up the developmental and psych concepts. Finally, let's hit the home stretch with the critical perfusion issues.
All right, home stretch. Let's talk perfusion, specifically heart failure and the critical drugs. This is the moment we pull together everything about volume, pressure, and the metabolic demands of the body.
Exactly. And when we talk about heart failure, we're really just defining a state where cardiac output, it's just not enough. It can't meet the metabolic demands of the tissues.
The pump is failing. Simple as that.
The pump is failing to deliver, or in some cases, it's failing to accept the blood it needs to pump in the first place.
And before we get into any meds, we have to really nail the pathophysiology because the treatment completely depends on what part of the mechanics are broken. So let's talk HFpEF versus HFrEF.
Yeah, the NCLEX focus here is all about the architecture of the heart wall. So diastolic heart failure, that's HFpEF. Heart failure with a preserved ejection fraction.
Preserved. That's the key word.
It is. This is a stiff wall issue. Think about it. After years of chronic strain, usually from uncontrolled hypertension, that ventricle wall gets thick. It's hypertrophied. It's rigid.
So the muscle itself is strong, maybe even too strong, but the actual space inside is smaller.
Precisely. The problem isn't the squeeze. That's why the ejection fraction is preserved. The issue is that the ventricle can't relax and stretch. Its compliance is terrible.
So it's an insufficient filling problem.
It's a filling problem. It's like a water balloon that's gotten really thick and muscle-bound. It can't expand, so it only holds a little bit of fluid.
That makes the treatment so much clearer. If it's a filling problem, you might not want to hit them with tons of diuretics and tank their preload.
That's a huge clinical point. You drop the volume too much, and there's nothing left to fill that tiny chamber. Now, contrast that with the other one, systolic heart failure, HFrEF.
Okay, so this is heart failure with a reduced ejection fraction. The classic stretched out, weak heart.
Right. HFrEF is the pumping problem. This is where you have actual damage, maybe a big MI, severe coronary artery disease. And the heart wall gets thin, it gets dilated.
So it fills up just fine, maybe even overfills, but it just doesn't have the muscle, the contractility to push the blood out.
The tank is huge, but the motor is weak. And the amount of blood it ejects, the EF, just plummets.
And this leads us right into Starling's law, right? With HFrEF, the heart is way past that optimal point on the curve.
Way past it.
Yeah.
Starling's law says, more volume in, stronger contraction out, up to a point. But in HFrEF, the muscle fibers are so overextended that any more volume just makes the contraction even weaker.
Which is exactly why our whole management strategy is about controlling two things, preload and afterload.
That's the game.
So let's define them. Preload is what? Volume.
Preload is volume. It's the stretch on the heart muscle at the end of diastole.
Yeah.
It's the load you deliver to the heart. So how do we manage it? We reduce the volume.
Diuretics.
Diuretics, furosemide, bumetanide, and a strict fluid restriction. We just lighten the load.
Okay. And afterload is pressure, the resistance the heart has to pump against.
Yep. For the left side, that's your systemic vascular resistance, your SVR. And if the heart is already weak, like in HFrEF, the best thing you can do is lower that resistance.
It's like opening the door so it's easier to push the blood out.
Exactly. And that's where we use our antihypertensives, our vasodilators, your ACE inhibitors, your ARBs.
Okay, this is perfect. Because if management is all about where the pressure is, then assessment has to be about where the fluid is backing up. Let's hit left-sided versus right-sided heart failure.
Simple physics. If the left ventricle fails, the blood can't get out to the body, so it backs up into the chamber right behind it.
The lungs.
The lungs. So left-sided heart failure symptoms are always about respiratory distress and pulmonary fluid overload.
Tell me what I'm going to hear when I put my stethoscope on their chest.
You are going to hear crackles. And not just any crackles. The key assessment finding is that they start at the lung bases and they ascend as the failure gets worse.
You'll also see pulmonary edema, right? The patient can't breathe, especially at night.
Tajameli can't catch their breath, and if it's really acute and severe, you get that hallmark sign.
Pink, frothy sputum.
Pink, frothy, liquid sputum. That means fluid is literally mixing with air in the airways. That's a huge red flag.
And if you hear those ascending crackles, the immediate move is to reduce the preload. Get that fluid off with IV diuretics.
Immediately. Now, that pressure from the left side backs up into the lungs, which then puts a huge strain on the right side. Eventually, the right ventricle just gives out.
And that's right-sided heart failure.
Right-sided is a failure to accept the blood coming back from the body. So if the left side backed up into the lungs...
The right side backs up into the rest of the body. Systemic.
Correct. So now you're looking for signs of fluid pooling everywhere else, heavy edema in the legs, fluid in the abdomen ascites, and, that really dramatic increase in venous pressure that you can see as jugular venous distension, JVD.
And that progression from left to right is how we get to what we call congestive heart failure, right? Walk us through that, starting with high blood pressure.
Okay, so you have years of untreated hypertension that's chronic, high afterload. The left ventricle works harder and harder. It gets thick. That's your HFpEF.
Eventually, it gets exhausted, it fatigues, stretches out, and fails. That's HFrEF. Now the fluid backs into the lungs. The right ventricle, which is, a low-pressure pump, is now facing this insane pulmonary pressure. It struggles, it fails, and now you have global failure. Systemic congestion, CHF.
That's a fantastic connection. All right, let's pivot to the meds, the high-risk, high-reward cardiac drugs, starting with digoxin. A cardiac glycoside with a really unique dual action.
Digoxin does two really important things. First, it's a positive inotrope. It makes the heart pump harder. It increases the force of that contraction.
And second?
It dramatically decreases the heart rate. It has a parasympathetic effect, kind of like stimulating the vagus nerve, so it makes the heart pump slower.
And that second part, the bradycardic effect, dictates the #1 safety check, the one you can never, ever miss.
The absolute rule is... You hold the dose if the patient's apical heart rate is less than 60 beats per minute, period. And you call the provider, we're trying to stabilize the pump, not stop it. And digoxin is famous for its narrow therapeutic range. The good dose and the toxic dose are really close together. So what are the toxicity signs we're looking for? Especially with vision.
GI upset is a big one. Nausea, vomiting. But the classic sign they'll report is visual changes. They'll see a halo or an aura, and they often describe it specifically as yellow or green.
And if we confirm toxicity, what's the antidote?
The antidote is Digibind.
Okay, one more detail on digoxin. It's a huge safety flag. It often comes in a glass ampoule.
Yes, and because of that, you must, without exception, use a filtered needle to draw it up. It prevents those tiny shards of glass from getting into the syringe and then into your patient.
Crucial. Okay, moving on to another class with that same heart rate rule. Beta blockers.
Beta blockers are a cornerstone for CHF. They decrease the workload, they decrease the rate, they decrease oxygen demand. And yes, the safety check is identical. Hold the dose. If the heart rate is less than 60, call the provider.
What happens if a patient just suddenly stops taking their beta blocker?
Oh, that's dangerous. You get this massive rebound sympathetic activity. Their beta receptors, which have been blocked, suddenly become super sensitive. You can trigger a hypertensive crisis, severe tachycardia, huge risk for an MI. You have to taper them.
Always. Next up, ACE inhibitors and ARBs. Their big job in CHF is to decrease the afterload.
They interrupt the RAAS system. They stop that powerful vasoconstriction, which lowers the SVR. The big clinical point here is that a lot of patients can't tolerate ACE inhibitors. They get that persistent, dry, hacking cough.
From the bradykinin accumulation.
Exactly. And if they get that cough, what's the move?
You switch them to an ARB. An angiotensin receptor blocker.
Right. It works further down the pathway, avoids the bradykinin issue, no cough, but you still get that same vasodilation and decreased afterload.
Perfect. Last in this group, nitrates, like nitroglycerin, mostly for angina.
Potent vasodilators. They reduce the oxygen demand on the heart. The assessment priority here is knowing when it's unstable. We teach patients the 3-dose rule. If your chest pain is still there after the 3rd dose of nitro,
It's an emergency. It's likely unstable angina or a full MI. Call 911.
right.
Okay, let's circle back to one specific diuretic, mannitol. We know diuretics reduce preload, but mannitol is special. Why?
Mannitol is an osmotic diuretic, and its superpower is that it's a huge molecule. It cannot cross the blood-brain barrier.
So this is for our neuro patients.
Exactly. In a situation where you have both fluid overload and increased intracranial pressure, mannitol stays in the bloodstream and creates this powerful osmotic pull.
It literally pulls the excess fluid out of the swollen brain tissue.
Pulls it right out of the brain, into the vascular space, and out through the kidneys. It's a lifesaver for ITCP.
Excellent. Okay, we've nailed chronic management. Let's make a hard pivot. Medical emergencies, circulation, and shock.
Okay. Shock is just inadequate tissue perfusion. The key is to figure out why it failed.
Let's start with hypovolemic shock. Usually hemorrhagic, the volume is just gone. What is the absolute first priority, even before replacing volume?
Stop the bleeding first. Always. If you have a massive active hemorrhage, trying to give fluids or pressors just pushes the blood out of the body faster. You apply pressure, you use a tourniquet, you secure the leak, then you replace the volume.
And what do we replace it with?
We start with isotonic crystalloids, like lactated ringers. But if it's bad, we're moving fast to blood products to get that oxygen carrying capacity back.
Okay, next. Distributive shocks.
Yeah.
Septic, anaphylactic. Here the volume is there, but the container has gotten huge from vasodilation.
Right. The vasculature has expanded so much that the fluid you have can't generate any pressure. So the priority is twofold. You have to reverse the dilation with vasopressors, and you have to rapidly give fluid volume to fill up that massive new space.
You have to do both. One without the other won't work.
Won't work. You need to shrink the container and fill the tank at the same time.
And finally, cardiogenic shock.
The pump itself has failed. This is the toughest one to manage because the problem is the heart itself. The priority is to correct the cardiac issue. Fix the pump.
In any shock state, we're watching the mean arterial pressure, the MAP. What's the calculation and what's the magic number we need for perfusion?
MAP is your systolic plus 2 times your diastolic, all divided by 3. And you absolutely must have a MAP greater than 60 millimeters of mercury to perfuse your brain and your kidneys. Below 60, you're in big trouble.
If the MAP is low, what are the 2 simple mechanical things we can do at the bedside before grabbing a drug?
Use gravity. Drop the head of the bed Trendelenburg and lift the patient's legs. That shunts a whole bunch of blood from their legs back to the core.
And that move is actually a diagnostic test, right? The fluid responsiveness test.
Exactly. You do that and you watch the blood pressure. If the BP goes up, even a little, it means they have fluid to spare in the periphery. They're fluid responsive, they need volume.
And if the BP doesn't budge?
Then they are not fluid responsive. The problem isn't a lack of volume, it's a lack of tone in the vessels. They need pressors now.
Which leads us straight into vasopressor administration. These are the big guns.
Yeah.
Norepinephrine, epinephrine.
And they are incredibly dangerous. The goal is to constrict the blood vessels, raise the SVR, raise the MAP. But rule number 1, all vasopressors are vesicants.
Meaning they kill tissue if they leak out of the vein?
They cause intense local vasoconstriction. If they infiltrate, you get severe ischemia, tissue necrosis. It's a catastrophe.
So, given that risk, what are the rules for access?
The ideal is a central line, always. But if you don't have one, you need, at a minimum, 2 large-bore peripheral IV access points. One for the pressor and a backup ready to go.
And how do we give them?
Always on a controlled IV drip pump. You never, ever push vasopressors in a syringe.
Never.
Ever. That causes a massive spike in concentration that can lead to limb ischemia.
Okay, but it happens. Infiltration occurs. What's the antidote?
The antidote is phentolamine. It's an alpha blocker that immediately reverses that vasoconstriction. And you give it via multiple little subcutaneous injections right into the infiltrated area to save the tissue.
Now, there are 2 situations where pressors just won't work. The first is a chemical imbalance.
Acidosis. If the patient's blood pH is too low, the pressors can't bind to the receptors properly. The acidosis itself causes vasodilation. So if your patient is on max dose pressors and their MAP is still in the tank, your first thought should be to get an arterial blood gas. Check for acidosis.
And the second situation where they're ineffective or even harmful.
Active hemorrhage. Again, if you have a massive bleed, giving a pressor is like turning on a fire hose. You're just pushing blood out faster. Stop the bleed first.
Okay, let's shift gears into codes. ACLS rhythms, we have to know which ones are shockable.
Shockable rhythms are electrical chaos. We're talking ventricular tachycardia if they're pulseless, ventricular fibrillation, which is just a quivering muscle, and torsades de pointe.
And a shock works by basically hitting reset.
Exactly. It's a massive jolt of electricity to stop everything, hoping the heart's natural pacemaker can take over again.
And after a shock, or to prevent it from happening again, what antiarrhythmics do we use?
We're trying to calm down the ventricular tissue, so we use amiodarone or lidocaine.
Okay, now the rhythms where a shock is useless. The unshockable ones.
That's a systole, a true flatline, no electricity and pulseless electrical activity, or PEA.
PEA is the tricky one. The monitor looks okay, but there's no pulse.
Right. There's an electrical signal, but no mechanical contraction. It's usually a mechanical or metabolic problem, like a massive PE.
So since you can't shock them, what's the #1 drug priority?
Epinephrine, AAP. And then every 3 to 5 minutes while you hunt for the underlying cause.
And no matter the rhythm, when a code starts, what are the first 3 things that have to happen simultaneously?
Start CPR, attach the monitor and defib pads, and get IV or IO access for your drugs now.
Okay, moving to the A and B in our ABCs, airway and breathing. This is where we see the first signs of trouble.
Absolutely. And tachypnea, a high respiratory rate, is one of the first and most missed signs that a patient is about to crash. The body is trying to compensate for something.
Let's talk about lung sounds. Let's say a patient is wheezing, but then the sound changes to this high-pitched, harsh crowing sound.
That is stridor, and that is terrifying. Wheezing is in the lower airways, the bronchi. Stridor means you have a severe obstruction in the upper airway, the larynx, the trachea.
Which means they're about to lose their airway entirely.
It's a medical emergency. You need to be setting up for intubation right then and there.
What meds do we try first?
Your fast-acting bronchodilators, albuterol, Acrovint. And if the stridor is critical, the last-ditch effort before intubating is nebulized racemic epinephrine to shrink that swelling.
Okay, let's differentiate the wet sounds. Crackles versus raunchy.
Crackles are that popping sound, fluid in the alveoli. If they cough up pink, frothy liquid, that's pulmonary edema, and the treatment is diuretics.
Get a fluid off.
Right. Raunchy is that continuous rumbling, snoring sound. That's thick mucus in the larger airways. The treatment there is a mucolytic, something to break it up, like N-acetylcysteine or Mucomeld.
And for oxygen delivery?
Yeah.
What's the max on a nasal cannula, and what's the setting for a non-rebreather?
Max for a nasal cannula is 6 liters per minute. Any higher is just irritating. A non-rebreather mask has to be set to 100% flow, which is about 15 liters, to keep that bag inflated.
Okay, let's tackle a really complex emergency. Smoke inhalation. It's a dual poisoning risk.
It is. You've got carbon monoxide and you've got cyanide. The big assessment finding is going to be that thick, sooty sputum. And their labs are going to show a severe respiratory or lactic acidosis.
Let's start with carbon monoxide. How does it kill you?
CO binds to hemoglobin about 200 times more strongly than oxygen does. It just kicks oxygen off the bus. And your standard pulse oximeter can't tell the difference, so the reading looks deceptively normal.
So what's the priority treatment?
You have to flood the system with oxygen to try and compete with the CO. 100% oxygen on a non-rebreather mask.
Now the second poison, cyanide. This one's different.
It's way more insidious. Cyanide doesn't stop oxygen from being delivered. It stops the cells from being able to use the oxygen.
They suffocate from the inside.
Literally. The cells can't make ATP. The antidote for this one is very specific. Hydrocobalamin.
And to clear out all those secretions from the smoke, we'd go back to our mucolytic.
And acetylcysteine again? Mucomist.
Okay, a related complication we see in severe trauma, like crush injuries or big electrical burns, is rhabdomyolysis.
Rhabdo is just massive muscle death. And when all those muscle cells break down, they release a ton of stuff into the blood, but the most dangerous is a protein called myoglobin.
And that's deadly for the kidneys.
It causes acute kidney injury, guaranteed. Those big myoglobin proteins go straight to the glomeruli and just clog the whole filtration system.
So what labs do we monitor, and what's the #1 intervention?
You're monitoring creatine kinase CK, which will be in the thousands, and myoglobin. And the priority intervention is fluids. Massive, high-volume fluid resuscitation to flush those kidneys and force the proteins out before they cause permanent damage.
That's a race to save the nephrons.
Absolutely.
Okay, let's move to neurologic emergencies. Increased intracranial pressure, IICP. The skull is a closed box. What's the very first, most significant sign that something is wrong?
It's not a vital sign. The very first, most significant symptom is a change in their level of consciousness, or their personality, or their judgment. It's subtle. It means the higher functions of the cortex are getting compressed.
And what about the pupils? How do they change?
The pressure starts to compress cranial nerve 3. So the first sign is usually unilateral. One pupil gets sluggish. You get unequal pupils. As the pressure gets much worse, you get the late terrible sign, fixed bilaterally dilated pupils.
When ICP gets really bad, the body launches this last-ditch catastrophic response we call Cushing's triad. What are the three parts?
Cushing's triad means brain herniation is imminent. You get 1, hypertension with a widening pulse pressure, 2, severe bradycardia, and 3, irregular, slow respirations, bradycypnea.
Okay, that combination of high blood pressure and low heart rate feels wrong. Explain why that happens.
It's a lethal feedback loop. The brain is starving for oxygen, so it screams for more blood flow. It triggers a massive release of norepinephrine to drive the MAP sky high to force blood into the skull.
So that's the hypertension.
That's the hypertension. But then the baroreceptors in the body sense this life-threatening blood pressure, and they trigger a massive vagal response to slam on the brakes.
And that's the bradycardia.
That's the powerful reflexive bradycardia. And the two together high systolic, low diastolic from the slow rate create that wide pulse pressure.
And the breathing is just the brainstem getting crushed.
Exactly. The respiratory centers are physically being compressed.
As the injury progresses down the brainstem, we start to see posturing. Let's differentiate decorticate from the more severe decerebrate.
Okay. Decorticate is flexion inwards. The arms flex in towards the core. This is bad, but it means the injury is still relatively high up. The cortex is out, but the midbrain is still driving that flexion.
And decerebrate.
Decerebrate is the worst injury. This is extension outwards. Arms are rigid, extended. This means the damage has gone lower, down to the pons and the lower brainstem.
Got it. Okay, for ICP management, we already said the diuretic of choice is
Mannitol, because it can't cross the blood-brain barrier.
And to manage that hypertension and Cushing's triad, what's the preferred antihypertensive?
Often it's nicardipine, a calcium channel blocker. It's great because it affects the arteries more than the veins, so you can lower the systemic pressure without increasing the venous congestion inside the skull, which would just make the IICP worse.
Positioning is also key, right?
Absolutely. Head of the bed elevated usually 30 degrees to help drainage, and you have to keep the head midline. Any turning of the head can kink the jugular veins and immediately spike the pressure.
And finally, IICP can damage the pituitary, which messes with ADH. What are the two endocrine swings we need to watch for?
If you get too much ADH, you get SIADH. You retain a ton of fluid, so you're looking at fluid volume overload and hyponatremia.
And if you get too little ADH?
You get diabetes insipidus or DI, the body just dumps water. You can have massive urine output, leading to a rapid fluid volume deficit and severe hypernatremia.
Okay, last major topic. Trauma and mass disaster triage. Here, the rules completely flip.
They do. In a mass casualty, you're not helping the sickest person first. You are doing the greatest good for the greatest number.
So let's run through the triage colors. Start with immediate or red.
Red tags are patients who will die soon without help, but who can be saved with a quick intervention. Think shock, a sucking chest wound you can seal, a major bleed you can stop.
Delayed or yellow.
Yellow tags have serious injuries, like big fractures, but their breathing and circulation are stable for now. They can wait a few hours.
Minimal. Green.
The walking wounded, sprains, minor cuts, they can wait the longest or even be told to go somewhere else.
And the toughest one. Expectant or black.
Black tags are for injuries that are unsurvivable with the resources you have. Or patients with no signs of life, no pulse, no breathing. You have to divert resources away from them to save the reds and yellows.
Which brings us back one last time to a core principle. A patient with a gunshot wound, low BP, high heart rate. What's the priority?
Stop the bleeding. Always. Control the hemorrhage. Nothing else matters if you don't.
Okay, last specific trauma. Burns. What's the immediate fluid risk and what's the fluid of choice?
The skin is gone, so fluid is just evaporating and third spacing like crazy. The immediate risk is profound hypovolemic shock. The fluid of choice is lactated ringers, LR, because it's closest to the body's own fluid.
And with all that cell destruction, what's the immediate life-threatening electrolyte problem?
Hyperkalemia. All the potassium that was inside the cells is now in the bloodstream, and that can cause fatal arrhythmias. You have to stabilize the heart with calcium gluconate and then shift the potassium back into the cells with insulin and D50.
And the swelling in a burned limb can cause.
Compartment syndrome. The burned, non-elastic tissue acts like a tourniquet as the muscle underneath swells. It requires an immediate espirotomy to relieve the pressure and save the limb.
And for infection control, what's the initial dressing and what vaccine do we have to check?
The initial dressing should be cool, dry, and sterile, and you absolutely have to check their tetanus vaccination status. Oh, and if they're going to use silver sulfadazine cream, you have to check for a sulfa allergy first.
This was a rapid, deep review of some of the most high-stakes material, perfusion and emergencies. We covered heart failure, the rules for drugs like digoxin and vasopressors, shock, and the critical signs of a neurodisaster like Cushing's triad.
You've really synthesized a huge amount of information here. Just remember to always go back to your ABCs. Airway, breathing, circulation, the ability to see the priorities, stop the bleed, fix the acidosis, a flood with fluids for rhabdo. That's what saves lives.
You now have the knowledge required to prioritize patient safety and crush the exam. Focus on the rationale, the why behind every rule we discussed today. That deeper understanding is your safety net.
We wish you the absolute best of luck on your final exam. You are ready. We'll see you next semester.